All right, let's talk about VBG and ABG, and then we'll move on to talk about other things. So why do we do VBGs? So obviously, arterial blood gas is the standard. Venous blood gas is something that we sometimes do, sometimes we don't do. Okay. So how do we make an ABG, VBG, and vice versa? So if I throw at you a VBG, would you know what the patient ABG should be? Yeah, that's the key. 7.4. So by definition, just so you don't remember, I don't want you to remember too many things. The VBG is more acidotic than the VBG, obviously, right? It's coming from the veins. So when you have a pH of 7.4 on the ABG, the pH in the equivalent pH in the VBG is 7.36, so 0.04 less, right? And if I give you a PCO2 on the ABG of 40, the PCO2 obviously is going to be 45 on the ABG, higher by 5. And that's the key, really, is that the PCO2 is the driver here. The PCO2 coming out from the tissues is 45, the mixed venous blood gas, and so it's higher than arterial, and the 5 of PCO2 results in how much change in the pH. As we said before, every 10 changes of the PCO2 results in a change of 0.08 in the pH. So that's why 5 results in 0.04 in the opposite direction. So that's no brainer. So if you just remember, so you don't keep forgetting things, if you just remember that the VBG is higher than the ABG by 5 in the PCO2, then you can make up the whole thing, right? So that's the relationship between mixed venous blood gas and arterial blood gas, okay? Now, so by just telling you this, it seems to me more prudent to do VBGs on people, unless you have an A line, right? So if you don't have an A line, and you're gonna have to draw the blood gas all the time, every time, we do in this ICU 40 blood gases a day on our patients. 40. That's a lot. So typical patients with lots of changes on the vent and stuff like that, you're probably gonna get like 6 blood gases a day. Imagine somebody sticking your radial artery 6 times a day. That's too much, all right? Of course, you can say, okay, we will have to put an A line then. Well, it's not better, because you're gonna put the A line, you're gonna put the catheter there. That, it will invite thrombosis and complications, and later when you get old, if they want to get that artery and use it for cabbage or something, it's gonna be difficult, or not able to use it, or if they want to use it for a fistula, for a dialysis patient, also that artery is not going to be the same. And it's another procedure with more complications to the patient. And most patients, we don't really need to know the exact, pH. What's the difference between pH of 7.36 and 7.34? No big difference. So, if it's off by a little bit, that's fine. So that's the basis why we do a VBG more than an ABG, okay? But there are other things that make the VBG even better than an ABG in certain situations. So the PO2 in an ABG, let's say on room air, is equal to age. 100 minus age divided by 3. 102 exactly, just to be exact. 102 minus age divided by 3. So if you're a 30 years old on room air, you should have a PO2 of 92. The normal mixed venous PO2 is 40 millimeter of mercury. So that's millimeter of mercury, that's millimeter of mercury, okay? So obviously we want the PO2, we want the PO2 to because it represents oxygenation, right? This will give you, the equivalent of this is 100% oxygenation. That's the saturation. Comes also on the blood gas slip, and this is 75% oxygenation. And that's what happens. The blood goes in, 25% is sucked away at the tissue, and then 75 comes up reoxygenated and so on. Now, if you think about, what is what's is ideal, or what's more important for oxygenation in an ICU patient? Is it the PO2 or the saturation? I would say it's a saturation, and not this saturation. It's a saturation that comes from the pulse oximeter, right? Why? Because we have the PO2 here, which is a measured value. The saturation is calculated based on the PO2 in an idealized curve. So if this is your oxygen hemoglobin dissociation curve, at 90 millimeter of mercury, this is the PO2 here, it will give you 100% saturation. We know that from the curve, right? These are facts. At 40 millimeter of mercury, it will give you 75% saturation. And at 27 millimeter of mercury, it happens that I remember that number, equal 40% saturation, right? More than 90, this will be 100% still, right? Now this curve is not, these are the normal curve. So acidosis shifted to the right, alkalosis shifted to the left, warmth shifted to the right, cold shifted to the left, and high 2,3 DPG shifted to the right, and low 2,3 DPG shifted to the left. Okay? Diphosphoglycerate or whatever. Right? So this, in a normal situation, we have somebody with respiratory failure in the ICU. What is hypoxia is usually, coinciding with or coming concurrent with? It's concurrent with acidosis usually. So the patient is acidotic and the curve is shifting, and then you get a saturation. And how many times you saw? How many times? I mean, you probably, but how many times I've seen a patient with, the nurse or the PA or the respiratory therapist comes to me with a gas that says 55 millimeter of mercury PO2 with a saturation of 83%. On the blood gas slip, it says 55 millimeter of mercury and 83% saturation. That's an ABG. Yes, of course, because 55 millimeter of mercury would be about here, 80% saturation, right? And I go to the room and I find that the patient with the pulse oximeter with good breath is 93, 94%, right? Most people, unfortunately, will believe the blood gas because the blood gas is in the lab. The lab doesn't make any mistakes. It comes out, but this one is on the finger, so we're not. Of course not. It's the opposite actually. As long as you have a good pleth, then you have. This is the pulse oximeter saturation. That's a measured number. So we have a measured number here, and we have a measured number here on the gas slip. This one on the gas slip is not a measured number. It's a calculated number. In the ICU, we stopped using calculated numbers since we had our disaster, calamity with the swan, right? After the fall of the swan, we stopped using calculated numbers. No more. That's how we burnt that device, because we kept on using calculated numbers, right? So we use measured and measured. So now we have two measured numbers. We have a measured number saturation on the pulse oximeter with a good pleth, and we have a measured number PO2 on the blood gas slip. And one of them is saying 55, which is alarming to us, because it's less than 60, right? I'm sorry, I forgot to mention another one here. 60 millimeter of mercury is 90%. That's where we start getting a little fuzzy here, and that's where the curve starts to, fall down. That's, that's the flat part of the curve here, and that's where it falls down, 60 equal 90. Okay? So 55 millimeter mercury will be very alarming to us, and below 90 is alarming to us here. But here it says 93%, and this says 55 millimeter of mercury. So which one should I believe? So let's go to the basics. What is the determinant of oxygen carrying capacity of the blood? Right? This equation, we need to not memorize it. We need to make it up as we go. So basically, what determines the contents of the blood? So we have to think about where is the oxygen is carried, and it's carried on the hemoglobin. Right? So if it's carried on the hemoglobin, then hemoglobin is the first thing we're gonna put here. Times how much, how many milliliters of oxygen is carried on 1 gram of hemoglobin, which is 1.3, roughly. Times, is the hemoglobin fully saturated? Is it fully saturated, carrying the 1.3 every gram? So that times saturation. Because the saturation of oxygen, when we say saturation, that means the saturation of hemoglobin. Right? That's by definition, has to be tied with the hemoglobin. Plus, so that's the part that is carried on the hemoglobin, which is the major part, plus PO2 times 0.003. So basically, you have the saturation that determines the majority of oxygen, 99% of oxygen in the blood. And then there is another small part of oxygen that is dissolved in the plasma. Plasma is not supposed to carry oxygen, right? But it carries oxygen when the pressure is too high. So that's why the pressure, that's how you remember. The pressure is tied to the plasma and the saturation is tied to the hemoglobin. So by just looking at this equation, it looks to me that the saturation is more important for oxygen carrying capacity than the PO2, right? So why do we even need to do PO2 then in an arterial blood? Why is it important then? Why we keep harping on PO2 for this part of the curve? For that flat part of the curve after the 60 millimeter of mercury. Because after the 60 millimeter of mercury, then the changes in the millimeter of mercury is not gonna really, especially if you reach to 90 and it's 100%. After that, there's only one reading on the saturation. It says 100% all the time, right? But you could be, right, on BiPAP, and your PO2 in the arterial gas, for example, is, 150 millimeter of mercury, and then tomorrow it's 100 millimeter of mercury. That's bad. There's more fluid in your lungs or something like this that's happening, right? But saturation is going to still read 100%. So that's when it's important. So basically, what we're saying is the PO2 in the arterial blood is only helpful in floor patients or less sick ICU patients or step-down units or something like that, right? But it's not really helpful in ICU patients. There are certain situations when it's helpful in ICU patients. If you can't get the pleth, somebody who can't get, on pressors or cold or something, you can't get a good pleth, then you have to do a PO2. And also for research purposes, when they want to do the PF ratio, right? I don't do PF ratio, it's really a useless measure. We can talk about it later. But PF ratio is how you define ARDS, for example. The PF ratio, the PO2 divided by the fraction of oxygen that's being inspired, and that gives you how sick the patient is and stuff like that. Well, we know how sick the patient is. He's requiring all of that oxygen. He's sick. He's ARDS. We know it. So it's not a big deal, right? So that's why, going back to our question again, between we talked initially about the easy part of VBG and ABG, and we said VBG pH is 7.36 and PCO2 45. PO2 we said 92 millimeter of mercury, and this one is 40. So we are what I just explained to you right now is that this is not a really very important value that we have to stick the patient 1,000,000 times in his artery. because we want that value. Because if we have a good pleth, we will get the saturation on the finger. And that is the end all. That's what we want, right? That's is better for oxygen carrying capacity, right? And it's not a calculated number, it's a measured number. Now, so I give you two reasons now. Okay. Now the third reason, right, is this one here. You can argue that even the mixed venous VBG is actually better than an ABG even. That's a little reaching. Why? Because the mixed venous PO2 depends on four things, I'm sorry. Right? It depends on four things that affect the mixed venous O2. So what are the determinants of mixed venous O2? So I'm going to write the equation, but you don't have to remember it from the equation. The equation is difficult to remember from. But let's say the oxygen consumption. So the oxygen consumption of the body per minute equal the blood that is going into the vein, in the arteries, and then minus what the tissues are taking, and minus what's coming in the vein, right? So basically, if I want to know how much the tissue is extracted from the blood, I just see what's the arterial contents of the blood. So contents of the blood in the arterial blood, minus contents of the blood in the venous blood, right? If you going this way, extracted, coming out, then now I know how much consumption is. But it depends also on how much the blood is going, how fast the blood is going, so times the cardiac output. Right? That's clear, right? It's easy. What's going in the tissues, what's coming out of the tissues, that tell you consumption by 100 cc's, through 100 cc's of blood. And then how fast the blood is going is determining really how much is this, the consumption per minute. And that, by the way, this is the Fick equation. If you remember the Fick equation, that is the equation that is you get from the Swan, that is an equivalent of the thermodilution cardiac output. You don't have to do the thermodilution cardiac output. You can do the Fick equation. Some people say it's actually more accurate. And the way it's done, by the way, just so you know, we assume to get so the Fick equation is a way. This is a little tangent on what we're talking about. This equation is actually designed to get the cardiac output, right? So what you do, you know this, the contents of the blood and the arterial blood, because you get a gas and you get the contents, right? And you know this because you're getting the mixed venous gas from the Swan. And here, this one, that's the assumption here. You assume that it's 3 mLs per kilo per minute. The oxygen consumption of the body, that's the normal oxygen consumption of the body if you don't have, thyrotoxicosis or sepsis or fever or whatever. And if you plug all of this, then you get the cardiac output, right? So if we take that equation and even simplify it even more, or not simplify it, like unravel it a little bit more, remember we said the oxygen content is hemoglobin times 1.3 times saturation, right? Do you know that when we do this equation, we ignore the second part of the equation, the PO2 times 0.03, that's so negligible, we even ignore it. You can write it, but it's not going to affect anything. Minus, that's the saturation, right? Here, hemoglobin times 1.3 times venous saturation times cardiac output. So, from this, we know that the mixed venous O2, the cardiac output is affected by what? Mixed venous O2, hemoglobin, arterial oxygenation, and oxygen consumption. All of this affecting, right? All of the others in the equation are affecting the cardiac output. So this is the difficult part to show it to you, but it's part of your, parts of your curriculum, parts of your knowledge. You have to know this equation anyway, huh? But the easy part to show it to you is that basically what we say is that the mixed venous O2 depends on two things, and then it's gonna branch: delivery or consumption, and consumption. Huh? Delivery depends on three things: cardiac output, hemoglobin, and arterial saturation. Same like the equation here. And this is oxygen consumption. So that's the same equation as this. This is the simplified way of looking at it. Is that the mixed venous O2, this number here, is dependent on delivery of oxygen, which is cardiac output, hemoglobin, and arterial saturation, or consumption, or end consumption. Okay? So by saying that, that means what? That means that this number is gold. That's what Emmanuel Rivers based his early goal-directed therapy on, right? For sepsis, we know this number is known from before, that that this number can tell you an idea about the cardiac output. This is what we need really. Hemoglobin, I can get it. Arterial saturation, I have it. Consumption is unmeasurable. You just say, okay, well, his consumption is normal, right? This is the one that I really want, right? How many monitors are there to measure cardiac output, right? And this is going to give us an idea about cardiac output. That's amazing. So that's why if you remember in the sepsis protocol, we say if the patient has a mixed venous PO2 less than 40, we actually give him dobutamine, even though he's septic. We give him an inotrope because it tells me that he has a low cardiac output, right? So that's very amazing, right? So if you're in the habit of sending VBGs in an ICU as opposed to an ABG, then you are getting every 4 hours or whatever you're ordering, every 8, every 6 or whatever, you are getting a look into, which I don't know if you guys are doing that already, but that's the ICU 2.0 for you. You're gonna start looking at not only at the gas and the pH and all this, you look at the PO2. The PO2 is gonna tell you if the patient needs dobutamine or not, or maybe he's bleeding and we don't know. That could be the first sign of bleeding. If you're not sending hematocrits frequently, if you're sending CBC every day, but VBG every 6 hours, and then you see suddenly the VBG, the PO2 and the VBG went from 45 to 30, or less than 33 that we have here, that means the patient either bleeding or low cardiac output, or has fever. Okay, well, he doesn't have fever. His saturation is fine. Then what's going on here? So when we send the hemoglobin normal, then it has to be the cardiac output. So that's an amazing advantage of VBG over ABG. You can never get that with an ABG, right? Add to that, which is it's the same point, but add to that, if this is high, what does that mean? That means that it's distributive shock. It actually rules out. I like the high. I don't like it, but it's easier diagnosis when you have a high VBG, because that tells you that you can rule out cardiogenic shock. You can rule out hypovolemic and hemorrhagic shock. It was the same, and obstructive shock. These all are ruled out just by high VBG. So if you're running around, I'm sure this question comes all the time for you, is that patient is dropping his blood pressure, and you keep on just wrapping around in circles, trying to, why? Maybe cardiogenic, maybe he's bleeding, maybe he's dehydrated, maybe whatever, and you forget to look at the VBG. Look at the VBG. If the VBG is high, then it tells you, the PO2 and the VBG, mixed venous VBG is high. That will tell you that the patient is not cardiogenic, for sure, 100%. I can put money on it. It's not cardiogenic, it's not hypovolemic, and it's not obstructive. When it's low, it's fair game. It can be anything. It can be any type of shock, because now we found out, thanks to Emmanuel Rivers again, that we found out that basically the VBG, we found out that the low VBG or low PO2 on the VBG can be in early sepsis. So now everything is muffled. So if it's low, it can be anything, right? But if it's high, but anyway, see how much information can we get just from a VBG? All right, so this is, I don't know how to remember how many things, but maybe 3 things or 4 things that we said. We talked about the VBG and ABG, and why we do VBGs in this ICU. right? So let's say, let's talk about a couple other things, minor things. For example, let's say I have somebody who I suspect that his change of mental status, he was a little drowsy, is from acidosis, right? It's respiratory acidosis, right? He's retaining CO2. He's a little sleepy, so I want to find out. So I send the respiratory therapist goes in. He gets the nice long needle that he has, and he goes here like, trying to get the ABG. He couldn't get it, then he moves around and he does like this. And the patient who is kind of sleepy start to do what? I start to scream and start to have severe pain and then breathe so fast because he's having severe pain. Right? Anybody who has pain breathes fast, right? So now he was running at like this, 7.28, 55, right? When I stabbed him like this, then he breathed fast. 15 will give you a change of what? So as I'm sticking that patient, during the time that I'm sticking the patient, he's breathing so fast because 15 millimeter of mercury of PCO2 changes the pH by how much? 0.12, because each 10 changes the pH by 0.08, so now 15 changes by 0.12, so now it becomes 7.40. So the patient now is like this, and I'm like, I don't know why he's sleepy. When I just attacked him with a monster with a needle in his hand, you know, like a lion with a big tooth, just to get an, you know, eating his arm. You know, of course the guy's gonna be screaming and he's gonna be breathing fast. So it becomes confusing, more confusing than a VBG, which somebody goes in and just like does like this, and nobody even, you know, even wake up for it. Even I can show you other things that actually makes even some people spin, you know, because some people are so ideologues, so much of an ideologues. So I can spin you a little more if I say, in fact, this guy here went like this, 35. This is an exaggeration, but you know, let's say he's starting, whatever. Anyway, just for the interest of time, this guy went to 35. So this becomes now 7.44. And he has a lactate of 8. So some people say, that's 2 disorders. Which they're right, by the way, there's 2 disorders, but he has a lactic acidosis, and because there's a respiratory compensation of lactic acidosis, you should never, ever, ever overcorrect, right? You should, physiologic mechanism should not overcorrect. It should stay at 7.4 or lower, right? So if it overcorrects, that means there is a respiratory alkalosis too with it. And you know, some people say respiratory alkalosis started and then lactate, or lactate started and yeah, there is a respiratory alkalosis from the pain that we're causing. You know, so they're right in saying that, but then it puts him in a spin trying to find where is the respiratory alkalosis coming from when we know it's coming from the goddamn respiratory therapist, right? So that's that. So that's why still VBG is better than an ABG. Now there's some caveats here. All of the calculations that were done on the VBG were done on an upper body central line. So subclavian or IJ. So I can't confirm any of this, or it can't be as accurate as we think it is in patients with femoral line. We don't know if this actually holds true or not. The SWAN also that was included in those. So upper body central line and SWANs are close to each other, but we'll talk about the difference. Huh? So well, we can talk about it now. The SWAN causes a problem, right? The SWAN poses a problem because the SWAN was not actually tested in this in these VBG ABG things. Right? VBG, ABG things were only tested on the upper body central line. For SWANs, they were not tested. So if you're getting your VBG from the SWAN, so let's talk about it. This is the right atrium, this is the right ventricle, and this is your, right? SVC, IVC, right? Tricuspid valve, pulmonary artery. Okay? So the swan goes like this. The central line stops here. So if you get the swan, you get it from here. So your VBG, that's the actual mixed venous O2. That is the real mixed venous O2. Mixed meaning that you mixed upper body and central body and lower body together. You mixed them. Here, that's the central line VBG, the upper body central line, central VBG. Huh? And here, that's the lower body VBG. So there is some differences. The mixed venous O2 for real is actually gives you that's the one with the PO2 of 40 and the saturation of 75%. That's the normal here. The normal here is saturation of PO2 of 38 and saturation of 70%. I usually use those numbers even for this, but there's no big difference between them. Who proved that? So when I was a resident, it was blasphemy to actually do what we do now, which is a mixed venous O2 from the central line. The attending would come, probably will fire you on the spot the next day, because how dare you? You know, from here, you just basically you're not worried about you don't care about the rest of the body. You're just getting the mixed venous O2 or the venous O2, which implicate the tissue perfusion and consumption and stuff like that, only from the arms and the head.
Well, actually, even depending on the port for the swan, I mean, if you get it off the proximal port, it's close
It's
to
the
the
same
coronary
thing.
sinus. Yeah.
Yeah. So, but we were not getting it from we're getting it from here, you know. But in any case, what I'm saying is that you imagine that you're just worried about the upper body only. So, why is this? Can somebody tell me why is this lower than this? Because the brain uses more oxygen than all the other parts of the body. So that's why it comes out so desaturated from the brain, and from the lower part probably come out higher, maybe 80% or something, and they mix together, it comes out 75%. But again, Professor Rivers proved that this relationship stays for all of the situations, right? He did a pilot study before doing his study about sepsis, early goal directed therapy, and he found that it always goes together. If this becomes 40, this is 45, and so on. They go on very similar to each other. So he said, why do we have to wait? As an ER physician, so he said, why do we have to wait for the patient to go to the ICU, get admitted, and then the next morning the attending comes in and valse in the ICU and put a swan so we can know the mixed venous O2? Why don't we just know it from here? If it's so close to each other like this, why don't we? And that's the revolution from this article. The rest is history. That's why everybody's doing mixed venous O2 from the thing. In fact, just a tidbit there is that Rivers himself was, every study has to be financed by something. It was financed by his own company that made the catheters that actually measure directly the mixed venous O2 from here using a fiber optic sensor. Measures continuously. And that, by the way, throws the other argument. One of the arguments that I said is that measured and calculated. This is measured. The saturation here that is coming from that catheter is measured. When everybody took that from him, they made a mistake. People who adopted the early goal directed therapy and said, okay, we're going to look at the saturation then. Because he looked at the saturation, right? They made a mistake, because when they looked at the saturation, what saturation they were looking at? They were looking at saturation in the blood gas slip. You have to send the gas from the SVC, and the machine calculates it based on idealized curve. Remember the curve I showed you? All right? Based on an idealized curve, and when you get that idealized curve, then you say the saturation is X, and the saturation is not that. The saturation, this is a calculated number, for him was a measured number. So that's a big pitfall in people who are following early goal directed therapy. that they go by the saturation. That's why I go by the PO2. And this is an easier number. That's why I keep telling people that. Anyway, so this is different. What's okay? So can somebody tell me what a condition that makes, or two conditions that make these two separate from each other? Yeah.
VSD. If you have a VSD, you can have a step up. Because there's a shunt.
Yeah, but you have to have a left. Yeah, it's a left-right shunt, and you're gonna have some more oxygenation in this one. But these things are rare. I mean, seizure is more common. If somebody has seizure, then this is gonna drop so much. This is gonna drop relatively. It's not gonna drop that much. It's gonna be diluted by the other stuff. Or pentobarb coma, which is rare. Somebody's like not doing anything or like completely, we're doing a pentobarb coma so we can put the brain at a basic energy expenditure, isoelectric activity, and then that will result in a difference, huge difference between the two numbers. Okay, so these numbers here, just, are you following? This is what we do, and our claim to fame is that it's very close to the real mixed venous O2, upper body venous gas is close to the mixed venous O2, right? I'm talking about fallacies of the VBG, right? This is the start of the fallacies, right? Now here, femoral, we don't know. Moreover, peripheral VBG, which we do a lot, right? Then we say, I like to do the VBG from the guy here because, I don't want to stab him, right? Peripheral, we don't know the difference, but it's very close. So I can tell you if I have and that's, by the way, we took that from where? From our ER colleagues, right? They do VBGs on all of your ketoacidosis, diabetic ketoacidosis. They come here, they get VBGs, because, every time, imagine every time one of those people come and we do ABG every single time, it'd be a disaster, they're here every other week, right? So, and it complicates the management. You're gonna put an A line in each one of them, it's like crazy. So now we're gonna do VBGs on all of those, and it's a peripheral VBG, right? So it's close to this. It could be like 732, maybe that's different. It really can be anything. It can be too high, it can be too low, but it's within the range. So I can manage a whole DKA case without getting a single ABG, because it's within the ballpark. I know the difference here is 0.04, could be 0.06, could be whatever. So, you know what I mean? So that's that. So that's a big fallacy of it, but I don't think it disqualifies it, because by definition, if I'm doing only peripheral VBGs, that means I'm not even putting a central line in the patient. That means the patient is not that sick. That means let's not get hyped about it. Get the VBG and we'll move on, right? Now, that's why when you guys get called to the floor, for example, or here, and the nurse says, he looks like a peach, but his pH is 7.29. So let's consult the ICU. His pH on a peripheral gas is 7.29. But he looks great. The clinical picture doesn't match this pH. That's when I say what? Get an ABG. And many times we've seen, normal ABG, send them to the floor. Right? Or we're not taking him to the ICU. So you have to put the clinical picture with you. Right? But if you're following a COPD patient that is in the ICU or something, and his pH is 7.1, what's the difference between 7.1 and 7.16? There's no big difference. You're gonna do exactly the same thing for this patient, and you're gonna follow him until he wakes up and his pH is normal. Now, so that's one fallacy. Now the last fallacy I'm gonna say is, even with central lines, right, there is a disconnect between the mixed venous O2, upper body mixed venous O2, and arterial mixed venous pH and PCO2 and the arterial one. If you are on high dose pressors, where does this come from? It comes from here, actually. Somebody here came up with the idea, and we did the study here, actually. It's not a big study. We did 11 patients. And in those 11 patients, we looked at patients who very specifically have more than 20 mics of levo, right? Typically we use vaso on all of them, so it's that and vaso probably, you know. But all of them had this criteria that they have more than 20 mics of levofed per minute. And we had an A line and central line in both of them. So we can draw both at the same time. And we did this just simple test, yeah? And we find disconnect between them. The difference in pH could be as low as 0.04, or could be, the highest one was 0.11. So the pH here would be 729, where the patient has his normal pH here. Right? So that only applies for patients with severe shock, because in severe shock, you know, the perfusion to the tissues are much less, and then the tissues are very, very high, acidotic. Might not be completely, you know, so it doesn't represent the arterial O2, right? In fact, so yes, so if you have somebody with severe shock like this, with more than 20 mics of levofed, right, and you see that it's escalating, it's not going down, chances are you're going to be putting an A-line anyway in those patients and using the A-line for it. And even when you put the A-line, that's why, for example, you know, when I have a patient with A-line, with arterial line and a central line, I still ask the nurse to send VBG every 4 hours and ABG every 8 hours, right? Why is that? Because I want the ABG because it will tell me the real pH, right? But there's nothing that will tell me about this, the tissue perfusion, that the VBG will tell me, right? And the VBG, just a little logistic here that you probably don't know. The shoot that we shoot labs to the lab from here, the labs for some reason, weird reason, they do not accept ABG in the shoot. They accept VBG in the shoot. So ABG has to be walked down to the lab. So that's why I do ABG every 8 hours. That's all. You know, the reason is, by the way, some theoretical bullshit somewhere where they actually said that the shoot somehow, because there's like, I don't know, if the thing is closed completely, you know, like it's so sealed, and there's layers of, you know, wraps around it, the shoot will suck oxygen through the capsule, through the layers, through the nylon that's covering the thing, and through the syringe, and go into the syringe of the ABG and changes the PO2 to make it higher. What? That's crazy. So anyway, you know, it's not my fight to fight, so we don't send too many ABGs anyway, so that's fine. We give them that. So that's why we send the ABG by you know, which I really don't need. I need those, but it doesn't matter. So, in fact, we thought, I mean, this is, I always like to say at the end of my lectures, is that what is the ideas for research based on this? The idea that we really, really want to look at, and it's just, obviously we don't have enough people or enough time to do that, but there is the mimic data, and we can get the mimic data, we can look at it, and this is basically, this is like a, you know, big, huge database in BI for all ICU patients. We can look at it, and we can have the computer look at it and see if there is a correlation between the difference between the pHs done concurrently and the cardiac output. When we tried to do it, somebody tried to do it already. We looked at it and stuff like that. It's just we couldn't find, you know, ABG and VBG done at the same time. BI is not as crazy as us. They don't do the ABGs and the VBGs at the same time. They do it ABG once here, VBG 8 hours later, so it's not really representative. That could be a nice study done here, that has have a, you know, IRB approval, and we say we're going to do an ABG and VBG on patients with different levels of shock, right? And depending on how we're going to define shock, and maybe we'll have a cardiac output monitor and say, you know, if you have a cardiac output of 2, we send, but that requires tons of patients. Because you need those patients with cardiac output of 2, maybe 100 of them, right? And all of them had ABG and VBG at the same time to see if it's really clustering in a certain area. And then if your cardiac output is 3, 100 of them. And so it's so complicated. It requires a nice, good study that somebody's just a researcher that does that only for a year or 2, you know, and then finish the study. But that's a great, imagine that you can have a monitor that you can connect your, you know, you can plug in your ABG and VBG, and the monitor will tell you what the cardiac output is. That's amazing, you know, like in addition to all the other things that we have. So we talked about one fallacy, that it's only one area, 2 areas, the swan and the upper body, that's the certified. The other fallacy is the pressors that affects it. The third fallacies, I mean, that's important. You know, when you send a lot of VBGs, you have to know the fallacies too. When we talked about the advantages, we'll talk last disadvantage or last fallacy. If you know it, you'll be okay. Is where this is funny, and I'm trying with the lab to change it actually, but we're gonna change it one day. Where when we report the VBG, we report what VBG, like which site it came from, right? If the VBG comes from a central line, chances are it's gonna go in a syringe, right? If it comes by drawing from the lab, peripheral, the lab doesn't use VBG syringes. They will not draw anything in a VBG syringe. They like to draw everything in a vacutainer, right? So you know the vacutainer, they push this tube that has vacuum in it. All the tubes have vacuum in it, and it pulls the blood out. That's how they like to do it. So it goes in what? In the green top tube, right? The difference between both is that this one, without doing in a chute, without doing anything, it will suck air. So it will be hyper-oxygenated. So this one, the PO2 will be so high. This one is the normal one, this is correct. But this one, if you have a peripheral VBG, let's say I have a DKA patient and I'm doing a lot of peripheral VBGs on them, you are not gonna look at the O2. I tried to tell them, please cancel the O2. We don't wanna, it will cause a problem, right? And it potentially caused a problem because, you know, people are thinking that the PO2, like, you know, somebody was just thinking that the PO2, so this is the guess. Here is the guess, like this, 7.30, you know, 50, and whatever, and the PO2 is 40, right? Now this one here is 7.30, 50, and the PO2 is 150. So people think that this is an artery, especially if it's in a place that can go in the artery. If you have a vein here, somebody put a vein, like an IV here, and the patient is like, you know, big or something, then what's gonna happen is that, I don't know where the vein is, I start dig for it, find blood, advance it, and put the thing there, and I'm infusing medications in it and everything. And then I get a gas like this, and people freak out. Oh my God, it's an artery! It's not an artery, this is sucked in air, so this is wrong. So, in the green top, you know, by working here for some time, I know which one is which, because if the patient doesn't have a central line, it's probably the green top tube. And if the patient has a central line or a PIC line, that means it's this. Even if it's a femoral line, it's this, because the nurse drew it. But it'd be nice to know, you know, if green tube or not green tube because of this problem. All right? All right, any questions, professors? With the emphasis on fessers. All right.
I mean, so what's the main, are there any disease conditions or anything where the ABG would be the only real option?
Yeah, like for example, that's a good point, I should have said that. There's certain things that you only detected with the ABG, like carbon monoxide poisoning, right? If you have a carbon monoxide poisoning, and you don't know anything about the patient, most of the time you know that he's burnt in a closed space, there's soot in his nose, or the gas leak or something. You get some story, but if you know nothing about the patient, and you get a gas on room air, like this. 7.4, 39, 350 millimeter of mercury. What's wrong with this picture? What did we say the normal PO2 on room air? 102 minus H divided by 3. So his normal PO2 should be 92. Why is it 350? That means there's something else on Earth. That's it. You know, that means there's something else in the blood that's behaving like oxyhemoglobin, which is carboxyhemoglobin. That's why it gives you cherry red blood and actually fools both the pulse oximeter. Pulse oximeter gives you 100% and fools the gas machine, and it gives you 350 millimeter mercury. If you're not paying attention, you're gonna say, well, it's a normal gas. Let's look for something else. Maybe it has a PE, which is always the case. Always people think about PE before thinking of anything else. But this will be the first clue to send another gas to the lab and say, please run carboxyhemoglobin level, right? So that's ABG 100% there. I mean, how many cases we see of this? Very, very rare, right? Number two, and even when we see the cases, we know them, you know, so we don't need this. This is just like the rarest of the rarest of the rare. It happened once when I was a resident. I saw this actually caused the person who's dealing with the patient not to miss actually the carboxyhemoglobin, because he found this and he didn't look under in the gas slip. There was carboxyhemoglobin, but he didn't look for it. He wasn't looking for it. So that's one possibility. The other possibility, which happens a lot in the ICU, somebody who doesn't have a good pulse oximeter, like, you know, there's cold or rapid AFib or severe anemia, or somebody who's you know, on pressors or something. The pulse oximeter is not going to be picking up. Your only way to know the oxygenation is going to be that, right? And then the third thing is methylene blue. When you run methylene blue on people, which we run a lot for patients with septic shock and stuff like that, when you run methylene blue, these patients they drop their saturation. Their saturation is reading 85%, but their PO2 is normal. So that's the only way in patients with methylene blue to know that their PO2 is normal. You just do it every 2 hours and you know, assure yourself. Right? So these are some areas where the arterial gas has to be sent. You know, and then those people will do the gas. You know, so all of those, to add to that, people on very high pressures, they're already having an A line anyway, or we're gonna put an A line. Still, despite all of this, the majority of what you need in the ICU is VBG. 80% of what we send in the ICU is VBG. It does the job. And then after that, you can do for an ABG. And we talked about the one single huge advantage of VBG, which is tissue perfusion. All right? Thank you, professors.